It's really good to see so many of you joining us today on our open session for small animal surgery with an update on canine laryngeal paralysis presented by Dr. Robert Hardie. Before we start, I wanted to let everyone know that this session is being recorded and may be made available for access on our platform and used for marketing purposes. My name is Quincy Moore, and I am the Program Coordinator for Small Animal Surgery Blended Learning Program with Improve. With me tonight, I have Charlotte French, Head of Business Development. This evening, we are going to start with an overview of our Small Animal Surgery Blended Program and a quick demonstration of one of the interactive lessons taken from the program. After this, we will turn our attention to the exciting topic of laryngeal surgery with Dr. Hardie, who delivers face-to-face soft tissue practical sessions on the program out of the University of California and the Irvine Center. We'll be taking questions via the chat box at the end of the session, and there will be an opportunity for you to ask questions about the program and ask Dr. Hardie about his presentation. You can use the menu shown on the horizontal bar below to send your questions to us. While our programs are fully RACE accredited, we do not routinely submit open sessions for RACE accreditation. This is an hour of CE for you to take straight back and apply in clinic, and you will receive a CE certificate via email later this week. To start, Charlotte is going to give you a brief overview of Improve.
Yeah, so thank you, Quincy, and good evening, everyone. It's lovely to see you here. Some of you may be familiar with Improve, but just for those who aren't, we just thought we'd give you a quick overview. So Improve has been delivering CE to veterinary professionals globally for over 20 years and was the originator of modular CE. Now, modular CE involves learning being delivered on a monthly basis, running over 1 or 2 years, and leading to an exam and further qualifications at the end of the program. We're continually adapting and innovating our teaching and learning style, from face-to-face lectures and practical training to the more recent distance learning programs such as this one. We're a truly global company offering CE in countries as varied as Japan, China, Australia, and many European countries, as well as the US. In 2021, we delivered over 400 different CE courses, providing over 1,000 days of training to the profession. And Improve was created by a group of vets, such as myself, passionate about delivering high quality, continuous education to the profession, and this is still the case today. And by studying with us, you'll take back into clinic new skills, knowledge, enthusiasm, and the confidence to handle those challenging surgical scenarios. Our programs are accredited by the International School of Veterinary Postgraduate Studies, or ISVPS. And throughout the program, you can start working towards the General Practitioner Certificate or Postgraduate Certificate qualification, which is awarded through ISVPS and also linked to Harper Adams University in the UK. There are eligibility criteria applied to each award, and we encourage you just to, consult the website for information on this. So during our presentation, we will be showcasing our online small animal surgical program, which starts on the 1st of February this year. This is available to all potential delegates globally, and we'll be delivering, in addition to this program, throughout 2023, we're also delivering a further wide range of online, face-to-face and blended learning courses for both vets and vet techs, and you can find out more about all of our courses on our website. So our world-leading blended surgery learning program has evolved over several years, and it was developed to create an entirely new online learning experience. Essentially, the theory is delivered online and the practicals are delivered by specialists such as Dr. Hardie, who's kindly with us this evening, out of the University of California, the Irvine Center. You're supported on the program by module tutors who are specialists in their field, and all the lessons are presented in an engaging and intuitive style with various learning activities to keep your interest and to help you learn. These include the use of interactive quizzes, videos, labeling images, and drag and drop exercises, etc. And throughout the program, you've also got a discussion forum where you can interact with your peers and the module specialists. Being online, you can access your learning anytime you want to, enabling you to fit your studies around your busy clinic commitments so that it's easier to achieve that all-important work-life balance. So please, don't just take our word for it. Please just watch this short clip, which is actually from one of our current delegates on the Small Animal Surgery Blended Program. Which hopefully is going to load. Yeah. I don't think that is the, I can't hear any sound, Quincy.
Can you hear Charlotte?
No, there's no sound, sorry.
Okay. Now?
Still no sound, no.
This is on our YouTube page. Let's see.
The joys of technology.
Let me try. What about now? Can you hear?
Can't hear anything.
Jestrom. I'm from Sarasota, Florida, and I'm the medical director at Delegate Animal Hospital. Oh, I've known I wanted to be a vet since I was 4. So it's always been on the trajectory, and it's just kind of been a matter of taking the steps to get there. So I'm a general practitioner, but I do a large amount of surgery, particularly surgeries that other general practitioners in my area don't like to do, or maybe are not comfortable with doing. And I try to offer prices that are more affordable to the people in my community. So I've actually done many of the different courses that are out there, whether they're weekend courses or week-long practicals. But so far, out of all the things that I've been able to do, there hasn't been anything that's offered both didactic and practical training. So, it's one or the other. It's either lecture-based or it's hands-on. And so you're kind of limited when you do one or the other. It's really nice to have them both together where you have online learning and lecture-based, then transferring that into real-world practice in the lab and doing the surgeries themselves. We've been doing this course since January of this year. So for the past 10 months, we've had different modules each month, looking at different types of surgeries, focusing on different parts of the body and what, you have urogenital, you have thoracic, you have abdominal. So each month we're looking at something new. We're discussing with an online forum with the professor. We're getting online learning and lecturing. And so we've been doing that this whole time. And now we're able to translate that into real world practice on cadavers while we're here this week. And we'll continue to do that next year and return at the end of the year for our second practical lab. Yes, I think they've exceeded. I've been really surprised at how thorough the online lessons are and easy they are to learn from, especially having videos to reference when I'm trying to perform those surgeries in clinic myself. And then being here for the practical sessions, it's very thorough, very hands-on. We're getting to practice all of these surgeries in a small amount of time, but with a lot of supervision and direction. Absolutely. Yeah, there are a few others that I have my eyes on, but I'm going to try to focus on surgery for now. Yeah, I actually already have. My associate that I work with in my clinic, she really loves oncology and would like to offer chemotherapy protocols to our clients. And so she is currently enrolled in the oncology course by my recommendation, because I just have enjoyed the surgical oncology, the surgical course so much.
Great, thanks, Quincy. So yes, so just as obviously as I've already said, this small animal surgery course is set to start 1st of February, and the course will be spread out over 2 years. You'll have 14 online modules, each supported by a veterinary specialist. And as our delegate mentioned, there are 2 practical events. One focuses on soft tissue and the other focuses on orthopedic surgeries. And each event lasts for 5 days. And again, you can find the content detailed module by module on our website. So we're going to take a very brief look at some of the materials for you in a second. But just to sort of briefly outline, each online module includes the following. You get pre and post module assessments so that you can evaluate your progress. There are 9 interactive lessons, so essentially 9 interactive lessons per month, and 2 reflective lessons to help you reflect on cases and case presentations and reflect on your learning. All of the modules have downloadable notes, full notes, a full list of recommended reading, introduction and summary videos from the specialists, and again, all supported by a discussion forum where you can share cases with your peers and with the module tutor. So I think now, Quincy, you're going to kindly just give us a quick little look at the platform. We won't keep it too long so that we can hand over to Dr. Hardie in a second, but I'll hand over back to Quincy now.
Okay, so let's see. So this is our Moodle platform, which is where you will conduct your online portions of the course. As Charlotte mentioned, there are 3 weeks. Each week consists of 3 different lessons. There's also a knowledge quiz each week, and videos summarizing what your goals should be, and again, the notes that she was mentioning. So I'll give you a quick look at what one of the lessons looks like. So this is for our week 1 surgical basics. So this is just an introduction to the course, and for some of you would just be a nice refresher. So again, it's an interactive lesson. It tracks your progress along the side. You do have to work in order, but you can also go back and review. It does not allow you to skip ahead. So it is interactive. We have lots of different pictures, descriptions of tools in this case. There's also other demonstrations, and then there's also things like word matching. So for example, once you've covered a topic, they may have a section where you have to fill in the blanks. So for example, and then you check it, and if anything is wrong or whatever, you can re-practice and do it multiple times. So again, that's just one of the beginning lessons. And it moves through week 1, week 2, week 3. You also have access to case studies at the end, which is basically where you're given a case and it gives you different options for working through that case and how it will be recommended by the program tutor. So let me see if I can just get this to open real quick. So it tells you a little bit about the patient, the history, what was found during the clinical exam. And it is recommended that you do this on like a separate sheet of paper. And then as you move along, you check your answers. Okay, so you'll have different cases like that, which will be reflective of the course or for the module of that month. So for some examples, there's oncology, orthopedic, soft tissue surgery, things of that matter. Again, as Charlotte was mentioning, there is the discussion board where you can go in and talk to your peers and also the tutor and get feedback and ask questions about what you're learning, other people's opinions, things like that. And we also have our recommended reading list for additional reading to do outside of the course. So again, just a really quick, brief overview. I don't want to take up too much of Dr. Hardie's time. So I will go ahead and hand over to him so that he can move forward with his presentation.
Cool. Thanks, Quincy. You guys hear me all right? I'll
Yes.
share my screen and then hopefully tee all this up. That shows up as the full screen PowerPoint. Is that showing up well?
Yes.
I might just stop my video to make sure that my things run as smooth as possible. My login. It's not letting me back on for some reason. Well, I was just trying to put my video is out, but that hopefully that won't. There we go. Well, thanks everyone for joining the webinar tonight. As Quincy said, my name is Rob Hardie, and I'm one of the clinical surgeons or clinical faculty at the University of Wisconsin. And today I'm going to talk to you about one of my favorite topics, laryngeal paralysis in dogs, and just provide a kind of just a quick snippet of some of the elements of working up and treating these cases. And just a little bit of background on myself. This is a picture of moving on through. Oh, it's not advancing for some reason. There we go. Oh. There we go. Yeah, so this is a view of the campus. And if you look and squint, you can kind of see my office would be right about here. This is Lake Mendota in Madison, Wisconsin. And so the outline for tonight will be talking about laryngeal paralysis and talking about the signalment, clinical signs, a little bit of pathophysiology, anatomy, but mainly focusing on laryngeal examination and anesthetic protocols. I've got lots of videos teed up and ready to go that will give an example of kind of how I do my laryngeal exams. We'll talk about the drug protocols using the Doxapram as a respiratory stimulant, those sort of things to kind of give you a real good sense of what we're looking for and how to not be fooled by some of the pitfalls and complications that can occur with the different sedation protocols and the effects on laryngeal function and motion. So that'll be the main focus. And I'm just gonna stop my video so things play really good. There we go. So this dog here, this is the poster child for the kind of case we're going to be talking about tonight. And I'll play this little video clip. Hopefully the sound will come through, but this is be the typical case that we deal with when it comes to canine laryngeal paralysis. And hopefully you can hear that. So that's the typical patient, a large breed dog, typically older Labrador Retriever. And this dog most likely has laryngeal paralysis. That's most likely the reason for the upper airway stridor and sounds of obstruction that you're hearing. But as you'll see, we still need to rule out other causes. But just based on this presentation, we're going down the path of making the diagnosis of laryngeal paralysis. And so the typical signalement for this disease is typically an older, large breed dog. Labrador Retrievers make up about 60% of the cases of laryngeal paralysis. If you look across the different studies, they're overrepresented in most of those studies. But other common breeds would be the Golden Retriever, Spaniels, and then lots of other breeds. Just about every other breed has been affected, but to a much smaller degree. So we're usually talking about these three breeds here. The typical age at presentation would be about 11.2 years. Again, looking at all the studies, that's the typical age for presentation when signs get bad enough to seek treatment or to inquire about the changes that are happening. And then at the moment, females and males are equally represented in the cases that are reported. The typical clinical signs, it's usually slow and progressive in onset. And so most of the cases that I'm seeing when talking with the owners, they usually describe seeing some change about 6 months ago, 8 months ago, maybe a year ago, just depending upon the situation and the time of year. But it's usually slow and progressive over that time frame. Now, for those in general practice, you may be seeing these sooner just because of the nature of your clientele, but it's usually a slow progressive, and it's not unusual to have or to look back in the history and find something changing about 6 months ago or 8 months ago. Some of the classic changes would be or notice in a more hoarse or change in bark, where their normal bark just sounds a little more hoarse, a little more muted, a little more raspy. Respiratory stridor, and if you listen closely, and I like that initial video, it's worse on inspiration. So it's an inspiratory stridor, usually due to the fact that the larynx is just not opening adequately on inspiration, or there's some degree of paradoxical collapse of the arytenoids. Often owners will describe some degree of coughing or gagging after eating or drinking, or oftentimes after being recumbent or sleeping, they'll wake up and clear their throat or kind of cough and gag after being recumbent for a while. As it progresses, dogs become exercise intolerant. When normally they could do their normal walks or runs, that becomes harder and harder, to the extent where some dogs just can't even, walk to the mailbox or go outside when it's hot without some degree of intolerance. Kind of worst case scenario is when the paralysis would increase the risk for aspiration pneumonia. So any type of regurgitation event, or when eating or drinking, food goes down in past the larynx into the trachea and then into the lungs. And in some cases, it's pretty rare, but in some cases that aspiration pneumonia can be quite severe. And in most of these dogs, albeit they're older and often or may have other comorbidities, they often will have some degree of hind limb weakness and ataxia, as you'll see here in a minute. So they might have hip dysplasia, they might have bilateral cruciate disease, but on close inspection, close neurologic exam, you'll often pick up some type or some degree of proprioceptive deficit or weakness in the hind limbs that goes along with the changes in the larynx or the effects on the long nerves of the body. So just an example, another example of that classic respiratory noise.
We can't hear as well on that one, Dr. Hardie. I apologize.
Okay, I'll turn up as loud as it goes and see what happens. There you go. If it didn't come through, that's okay, but just another example of the stridorous breathing that these dogs get with laryngeal paralysis. And once you see a few of these cases, you can recognize it pretty clearly. Not to say that it couldn't be something else causing some degree of obstruction of the airway, but that's fairly classic for laryngeal paralysis. And to just touch on the pathophysiology, what's going on in these dogs, what causes the paralysis? And as you see in this bottom bullet, it's not well described, and there's actually only a few studies that have looked at the nerves that innervate the larynx or other long tract nerves, but it's part of a generalized degenerative neuropathy that's affecting the longest nerves of the body. And in a dog's case, that's the recurrent laryngeal and often the branches of the sciatica, the peroneal nerve. So those longest nerves are affected through what's looking like it's a degenerative axonopathy that eventually leads to loss of function of the cricoarytenoides dorsalis muscle. That's the muscle responsible for opening the larynx or abducting the arytenoid cartilages. And so when that nerve becomes affected, then the larynx can no longer open properly or normally on inspiration, leading to the clinical signs that we see. And this is just some histological slides or samples from Kelly Thieman's study in AHA back in 2010. And on the left panel, you'll see the samples from a dog with laryngeal paralysis. On the right, it's a normal dog. And you're looking at the recurrent laryngeal nerve and the peroneal nerve. So two of the longest nerves in the body. And in the affected dog, the dog with laryngeal paralysis, you're just seeing loss of in diameter of the normal axons, and then in between those is epineural fibrosis. And so it's a little hard to tell, but these nerves are packed together, they're dense, they're of greater diameter, representing the normal situation. And on the left, they're degenerated, and the remaining space of the surrounding space is fibrotic and replaced by adjacent epineural fibrosis. And one of my colleagues, actually, Dr. Susie Sample, is recently published on the neuropathology of the peroneal nerve in Labrador retrievers. And the findings that they're seeing are consistent with an axonopathy. And this slide just shows the sort of three different panels of the neuropathology. In the first panel showing a sort of a 2-year-old or a normal control dog, 12-year-old dog with mild clinical signs, and on the far right, a 13-year-old dog with severe clinical signs. And you can see the difference in the diameter of the myelinated axons, the decrease in axon density, and then the lack of regenerating clusters would just be a sign of lack of response or degeneration of these nerve bundles. And so, yeah, so at the moment, or all the information we have right now, it suggests this is a degenerative neuropathy affecting the longest nerves of the body, which again would be the distal extent of the recurrent laryngeal or cranial caudal laryngeal nerve, and then the longest branches of the sciatic nerve. And just an example here of that anatomy, you've got the vagus nerves coming down along the neck or the cervical region, and then off the vagus branch, the right and left recurrent laryngeal nerves, and then they send smaller branches, the perirecurrent, to the esophagus, and then the very terminal branches would be right here in the laryngeal area. And on this illustration just picks up from that previous one where you've got the caudal laryngeal nerve, or a branch of the recurrent laryngeal, innervating the cricoarytenoides dorsalis muscle. That's the CAD muscle. That's the muscle that actually abducts or opens the larynx on inspiration. So these long tracts become affected with this disease. And so that's just a brief review of the pathophys and the anatomy. And then the part that we're going to focus on from here would be sort of the internal, or the laryngeal examination anatomy. And this is what you'll see on exam. Obviously, intubating an animal, you would see this view, but remembering the parts, you've got at the apex, or the dorsal aspect of the larynx are the corniculate processes in the left and the right corniculates. And then just below them would be the cuneiform processes, sort of the wings or the flaps of the larynx. And then just in front would be the epiglottis. You can see here the laryngoscope just depressing the epiglottis. And then just caudal to that would be the vocal folds. And then dogs with brachiocephalic airway syndrome, that's often where you'll see the everted laryngeal saccule, as the mucosal folds just behind the vocal cords would come in and play in those breeds. And then obviously the space, or the rhemoglottitis, would be the lumen, where the gap created during inspiration and expiration. And so that's the anatomy. In doing surgery, there's obviously various procedures that would be done to manage this disease, but the typical tieback or left arytenoid lateralization would lateralize the arytenoid cartilage, really pulling back this corniculate portion and part of the cuneiform portion laterally to open up that side of the rhemoglottitis. So that's the anatomy. Looking at the diagnostic workup for these dogs, just based on that, say those two Labradors we just looked at, the signalment, the history, and the clinical signs, you can be fairly comfortable with a presumptive diagnosis of laryngeal paralysis, but you still want to rule out other causes of upper airway obstruction. And this little cartoon, a little image here, is just showing just that. What is your problem list? It's upper airway stridor, or coughing, or inspiratory dyspnea. And then what are some of your differentials? Is it a mass? Is it a tumor? Is it swelling? Is it collapse? Is it paralysis? And then your plan. We'll go through those things here shortly. But yeah, it's often based on signalment, history, and clinical signs, but still keeping an open mind until you've confirmed your diagnosis. And this is just an example of that. This is a CT image. This image on the right is a CT of a dog, older, large breed dog that had signs very consistent with laryngeal paralysis, which it did have, but for a different reason. And you can see here just a highly invasive thyroid tumor that has, in the process or over time, damaged or taken out the recurrent laryngeal nerves, which will run right along the lateral borders of the trachea. As you can see here, the recurrent laryngeal on both the left and right side have been engulfed and then became affected and no longer functional. And then the dog presented with signs consistent with laryngeal paralysis, but for a different reason. And in this case, due to just invasion of that tumor. And this tumor was such that it wasn't very bulky. It wasn't very external. A lot of this is hidden underneath the strap muscles. And so not easy for an owner to diagnose on their own, or easy for even us to palpate because of its sort of insidious nature. But just an example of one of the other differentials that can cause very similar signs or very similar presentation in an older large breed dog. And so, yeah, the cervical and laryngeal tumors, some sort of occult trauma or past trauma that has led to inflammation, scarring of their current laryngeal nerves. Laryngeal fibrosis, I've seen that with debarking procedures or with accidental or spontaneous regurgitation that has then caused trauma to the laryngeal mucosa and then subsequent fibrosis of the larynx. Collapse, not that common in large breed dogs, but nasopharyngeal laryngeal collapse, or then some other metabolic problems such as focal myasthenia gravis or an endocrinopathy. So just not a complete list, but some of the other differentials you want to be thinking about are ruled out before going too far down the road with your diagnosis of laryngeal paralysis. But with these things, you'll figure it out. And so the workup would be, obviously a physical exam and a neuro exam. And I'll show you some images of the neuro. Routine blood work, nothing obvious typically shows up, but you want to rule out other comorbidities, just a general sense of the dog's overall health through a routine CBC and chemistry panel, plus or minus any endocrine or metabolic testing based on any other signs or abnormalities on your screening blood work. But then cervical and thoracic radiographs, I'll show you some of those. And then if necessary, just like in that previous case, cervical or thoracic CT, if you were suspicious of any kind of cervical or thoracic mass that wasn't fully delineated on your radiographs or palpation, then a CT might be in order. And then ultimately the laryngeal exam, an anesthetized laryngeal exam is what's going to give you the ultimate answer with these cases. But yeah, so here's that example of a neuro exam, an example of that hind limb weakness or decreased proprioception in these dogs that is very, very, very common accompanying sign. They'll get around okay, but if you check their proprioception, it's often a bit weak, and that I think supports owners' comments about sort of being weak or a little wobbly or having a little hard time going upstairs or jumping into the car. Some of those things may be an orthopedic issue, but it's often a loss of proprioception as well. And so again, it's those long tract nerves and branches off the sciatic that are affected, resulting in decreased power replacement or loss of proprioception. This is an example of a lateral cervical radiograph. I always take these just to rule out any abnormalities that I couldn't palpate, or just something along the length of the trachea, some kind of intraluminal or small extraluminal mass, any evidence of collapse, any evidence of pre-existing trauma, anything like that you might pick up just to rule in or out whether this is an acquired neuropathy or something else. And I saw these kind of images will come back later on in some cases we're going to look at. And then thoracic radiographs, looking for signs of megaesophagus, aspiration pneumonia. This image on the radiograph on the right shows pretty classic pattern: air bronchograms, right middle lung lobe, classic aspiration pneumonia. And obviously we worry about this post-op in dogs that we do a lateralization on, but it can exist preoperatively. Obviously, if these dogs do have paralysis, then they're still at risk for aspiration, food and water going down the wrong way, regurgitation going down the wrong way, causing pneumonia or aspiration pneumonia. And so trying to determine whether this is present, and is it put your patient at higher risk, or just another comorbidity you're going to have to manage in the workup. And then this image on the left shows it's a nice example of megaesophagus, so you can see air in the esophagus. And this would be, it might be a concern. This dog probably has signs of some delayed or esophageal dysmotility. Maybe it's coughing, gagging more. Maybe it's regurgitating. So it makes it a little harder to recommend surgery or a lateralization in a dog that has megaesophagus or esophageal dysmotility because of the potential increased risk for aspiration afterwards. But this is what you're looking for in your RADs, ruling out or ruling in any masses, evidence of megaesophagus, evidence of aspiration pneumonia. And then onto the laryngeal examination. And I sort of, although it's all one big thing, I break it down into so what am I going to use for my anesthetic protocol, or what do the anesthetists like to use? What dosage are they going to use? What's the temperament of your patient? How does that play into the drug selection? The examination technique, which I'll go through. And I guess I'm fairly particular about that, or I do it in a sort of very particular way so I don't miss anything. And then the use of Doxapram, and we'll talk about that and how that plays into overcoming some of the side effects or the respiratory depression that goes along with many of the anesthetic drugs. So those three things, the protocol, the examination technique, and the Doxapram, use of Doxapram, we'll kind of go through from here. Starting with the anesthetic protocol, and the ideal protocol, the ideal drugs would provide good muscle relaxation. So you can position your patient, typically in sternal, open their mouth, get a good look without a lot of gagging or disruption of the examination. Hopefully it would maintain normal respiration rate, depth of breathing, so you get a nice good assessment of the airway function. Obviously, be a safe protocol, inexpensive protocol, and most importantly, maintain normal laryngeal function, which at the moment there are no drugs that do this, but minimizing any adverse effects is what we're looking for. And ultimately, you want to avoid a false positive diagnosis of laryngeal paralysis. So if you've got a dog and that 10-year-old Labrador that is showing these signs, the last thing you want to do is give it a false diagnosis and potentially recommend surgery if it's the wrong thing, or it's not fully affected at this point. And so a couple of years ago, I asked our anesthesiologist, what's your favorite drug? And I got a different answer from everybody. And so we'll kind of just talk a little bit about these different drugs as we go along. And the recent literature, there's about 4 or 5 studies that look at each of those, either in combination or separate. And it would take more than the time we have now, but I just wanted to pass on these references, and I have them at the end of the presentation if anybody wants to dive into any one of these or ask a specific question about them. But in summary of all those four studies, this is sort of the breakdown of kind of what I gathered from those studies. And it's none of it's really surprising, but it's just a matter of applying it to your patient and then titrating things accordingly. But obviously propofol and alfoxylone are sort of 2 induction agents or 2 common drugs that are used for looking at or doing laryngeal exams, and obviously they have a fairly high potential for respiratory depression or apnea, and then decreasing laryngeal motion. So it's one thing to induce the patient and look at their larynx. It's another thing to know whether that laryngeal exam is accurate. And these 2 drugs will definitely affect laryngeal function. And similarly, the rate at which you administer it. So if it's a fast bolus or a rapid bolus, that will or generally impacts the motion, laryngeal motion to a greater degree, and causes a greater degree of respiratory depression. So typically you're trying to titrate it in slowly to effect, recognizing that's challenging or can be challenging, but rate of administration does have an impact. And sort of contrary to older literature or older beliefs that pre-meds, drugs like acepromazine and butorphanol had a significant impact on laryngeal function or respiratory, causing respiratory depression. I think we're kind of moving away and actually have discovered through a couple of the studies I just mentioned that the use of these drugs actually improves the quality of the laryngeal exam and reduces the dose of induction agents. And so a little bit of ACE, a little bit of butorphanol, and a little bit of propofol is better than a lot of propofol. Is sort of one summary or one way to look at it. Or a little bit of dexmedetomidine and a little bit of butorphanol is better than a lot of dex. And so the pre-meds, and these are just two that were looked at in a couple of those studies, but others have been used, morphine, or hydromorphone as well. And so, so we're kind of coming full circle and acknowledging that pre-meds actually are useful mainly in reducing the amount of induction agent that is necessary, or propofol and alfaxalone, and improve the quality and the accuracy of the assessment. Dexmedetomidine is not really an induction agent, but also looks like a good choice. And in one study, compared to propofol, had fewer false positives and good quality of the laryngeal examination when compared side to side with propofol. And so warrants more investigation, but it's looking like dexmedetomidine would be a very reasonable choice as well. And if you like it for other reasons, then it's something to consider and get used to using in these cases. And we'll talk more about Doxapram, but very useful drug for overriding some of the respiratory depressant effects of the induction agents like propofol and alfaxalone. So even if you do use those drugs or have to use those drugs and get some depressant effect, that it can be overridden with Doxapram. And we'll talk a little more about that, and I'll show some videos of that impact or that effect. But ultimately, careful evaluation is necessary to avoid a false positive diagnosis of LARPAR due to the effect of these drugs. And so for the examination technique, kind of walk you through how I do it and kind of the setup that I use. And this image on the right is kind of what it entails, but the most important piece, I think, is this metal rack that we've created. It's just a metal rack. It's sort of 1/4 inch steel that we've just sort of bent into this rack, into the shape to create this rack that allows you to position the dog in sternal. They're kind of nice and straight. Head's not too extended. You can hook the canine teeth over the bar, and the jaw will just sort of hang down. Laryngoscope is in there, but it allows you to take your time with these examinations, position the dog really easily, really accurately. And most important, you don't have to have an assistant or someone helping you hold these dogs up, who then gets fatigued and tired and is moving, and then just complicates the matter. And it's a little harder to do an extended exam if you need to, when someone's helping you or holding the animal up. So I'm a real fan of using something like a rack, or there's other ways to do this with, IV poles and string and those sort of things, but something that you don't have to rely on someone else holding the patient's head up, so that you can take your time if needed. And the rest of the things are pretty basic. A laryngoscope with a nice long blade, got a good light source, nice long blade that you can depress the epiglottis carefully, gently, and then see around it or see over it. And then a tongue depressor. I usually take 2 of these tongue depressors together, and I'll use 2 of these. And one, you can kind of see it in this image here on the top right. If you slide that tongue depressor between the maxilla, the teeth, and the rack, and just slide it on down, it'll glide past the hard palate and then glide past the soft palate and just lifts the soft palate up. So with it in place right there, you don't have to use your other hand to hold the soft palate up to see the larynx. So it's nice. And in most cases, just sliding in there, it'll elevate the soft palate, and you get a nice, good view of the larynx, as you'll see here in a minute. Cotton buds or Q-tips to maybe probe the larynx, remove any saliva, assess the mobility of the arytenoids, and then flow by oxygen if you need it. And then ultimately just take your time. You don't see it here, but I'm usually sitting down, got a stool, got some oxygen for the dog, And so you can take your time and just make sure you get a good thorough exam and you don't miss your diagnosis or give a dog laryngeal paralysis that doesn't have it. And for me, that may take multiple cycles. If I'm using propofol, you know, they'll go through that phase of apnea, but then I'll sort of let them light up as much as I can, assess their larynx as best I can. And that may take a couple cycles, meaning, you know, 5-10 minutes sometimes. The things I'm looking for would be appropriate abduction and adduction of the arytenoid cartilages, or just proper in and out. So that the arytenoids, the corniculate processes, the cuneiform processes should abduct on inspiration and then relax or close on expiration. So it's, you know, and knowing the phase of respiration when you're looking is important. And oftentimes we'll have somebody call that out. And I think you might be able to hear that on some of the videos. But as you look, someone's just kind of telling you in, out, in, out, in, out. So you can make sure that that motion is appropriate. Assessing for deep breaths, you know, it's one thing to say, oh, I don't see any movement, he must be paralyzed. But if he's breathing really shallow, or she's breathing really shallow, then I'm not sure you want to, you know, make the call just yet until you're confident they're taking nice deep breaths that would represent or should adequately adduct or abduct the arytenoid cartilages. Another thing you want to do is check for the mobility of the arytenoid cartilages, and I'll use the tongue depressor or maybe the laryngoscope or maybe those Q-tips and just push on the arytenoids, and you should see, or they should lateralize easily. And you're trying to rule out any type of fibrosis or ankylosis that might have occurred that would, you know, cause immobility or lack of motion of the arytenoids, but not actually be due to paralysis. And I've seen a few of those cases, and in one I sort of underdiagnosed, or I wasn't aware, or I mistook the severity of it, and it made it harder to lateralize or to do the surgery. We got it done, but that ankylosis resulted in no motion or little motion when I probed or palpated the cartilages, but also made it a little harder to lateralize. And so I didn't get quite the opening that I was looking for with the surgery. But check for that with the scope or with a tongue depressor or Q-tips, and then ultimately use Doxapram if necessary to overcome any shallow or apneic breathing from the induction agents. And obviously, if you do that, then don't make the mistake of mistaking paradoxical movement for normal movement. And I'll show you some examples of that. Yeah, so this is just a kind of walk you through a normal exam and kind of what that looks like. And this is the situation here. So it's an older golden retriever, laryngeal exam. And this is actually normal. So you're seeing some nice abduction of the arytenoids, the cuneiforms, and the corniculates. And obviously you can't tell what phase of respiration, but somebody be calling out, out, out. They'd be calling out the breathing as you're watching so that you can make an accurate diagnosis. And just another example here, and this is just the dog's there. He's on the rack. He's got the tongue depressor in. He's got some flow by oxygen. And that's just our old handy iPhone showing us what's going on at the level of his larynx.
Because she missed her job.
Yeah, really good, man.
How's her first picture? Hey, Julie. Do you want to get my drugs out for Willow? Thank you.
So we'll just kind of watch, and we're looking for nice deep breaths and whether they have appropriate motion or not with those deep breaths. And we'll just sit there and watch until we're convinced. And this slide this video on the right, just another example of normal laryngeal motion. And even though we intubate dogs every day when we're doing surgery, we often don't look and kind of appreciate what, kind of what normal is. We just induce and intubate and don't take the time to look. And so, yeah, these videos help just sort of clarify what good abduction looks like. And if someone is calling out and appreciate that the rheuma glottis is actually getting bigger and not just moving or flapping or paradoxical. And this is another example here of this dog has got bilateral paralysis. Let me just see her chest. And so these video clips are running, they're running together simultaneously. And it's showing you what's going on in the larynx, at the same time, what's going on the outside, or you can appreciate the depth of respiration or the breaths this dog is taking when you look at the images on the right, the slide on the right. So kind of shallow breaths. You just got some Doxapram. Starting to get a little better. They're not real deep yet. But those are reasonable breaths. And what you notice on the left, there's nothing. So we're working our ways towards a diagnosis of laryngeal paralysis based on the quality of those breaths and the lack of motion on the left. So hopefully that makes sense. So that's a good useful example of seeing both the breathing and the chest excursions, and then seeing what's not happening with the larynx. And so, in contrast to those prior normal views, you really saw no abduction of the larynx in this dog. And so just another example of bilateral paralysis. This is about a 60-minute clip. And so just an example of how long I'm sitting there watching these dogs sometimes. And you can see the tongue depressor on the top. So that's that tongue depressor that holds the soft palate out of the way. And then the laryngoscope is just here on the bottom. And you can't really tell, but the dog is taking reasonable breaths. See a little bit of flutter. And you can see the cords move a little bit with the respiratory cycle, but that's actually a little bit of paradoxical movement. But if you thought this dog was taking adequate breaths, this would be an example of bilateral paralysis. Yeah. Maybe I'll just pause for just a second. Does anybody have any questions, or can I review any of those videos for anybody, or is that? I'll just ask Quincy if there's any questions or anything I can clarify at this point before I go any further.
I don't have any questions in the chat box
Okay,
yet, but we
okay.
can wait and see if anybody has one.
Okay,
to
yeah,
add.
just didn't want to. I can't see the chat, so I didn't want to just keep rolling on with if there was any burning questions. But yeah. So then, talking about Doxapram, the sort of the third part of my laryngeal exam. Doxapram is a centrally acting respiratory stimulant, and a lot of us might have used it back in the day doing C-sections, a little drop of Doxapram on the tongue or in the nostril when you're resuscitating puppies. I think that's gone out of fashion, but you might have used this drug in that circumstance. But but it's a centrally acting respiratory stimulant. And in this application, it helps override the depressant effects of your anesthetic agents, or in most cases, propofol or alfaxolone. And so with that, the doses here, I'm using a pretty low dose, or just about the bottom of the dose, 1/4 to 1/2. And I'll show you an example here in a second of the effects of either each of those two doses. But the label dose goes up to 2 mg per kg, which I think is quite high. And you can get some side effects, things like tachycardia and hypertension with doses over 1 milligram per kilogram. So be a little cautious when you use it. But at 1/4 or 1/2 mg per kg, I think it's very safe. You will see a little bit of arousal, a little bit of tachycardia with the 1/2 mg per kg even. But I'd say in most cases, the 1/4 mg is sufficient to overcome the effects of your induction agent. And it usually gives you about 8 to 10 really nice deep breaths. And it usually lasts about 30 seconds, 45 seconds, maybe a minute to kind of to peak, and then to come down again. And so I'll show you some examples, but I think it's very useful when your anesthetic protocol has just caused too much apnea. An example might be, your patient is just, if they happen to be a young patient, but if it's just a very excitable dog that didn't respond that well to its pre-meds, and then you had to use more propofol or had to use more alfaxolone, then you'll get that respiratory depressant effect, or that apnea. And then to overcome that, you might need Doxapram. So I find it very useful, and I use it in almost all my cases just to be sure. Some people just use it as necessary, but I use it in almost all of mine if I at all questioning the depth of respiration or the status of their laryngeal function. So this will be a couple slides here of showing you the difference in the 1/4 mg per kg versus the 1/2 mg per kg. It's fairly dramatic. Each one of these is about, I guess, about a minute and a half, so a little long, but bear with it, and you'll sort of see the difference. Same patient, 1/4 mg per kg IV, and then 1/2 mg per kg IV.
Yeah.
So again, we're just sort of camped out, got the tongue depressors in place, laryngoscope in place. We just gave the Dopram. Takes about 10, 15, 20 seconds to kick in. Respiration's starting to increase now. So contractions of the respiratory muscles. You hear some breaths.
How's their first practice? Hey, Julie. Do you want to get my drugs out for Willow? Thank you.
That was a cough, not a real breath. Another breath there, but not much.
Yeah. Getting it now.
So not much. That was a 1/4 mg per kg in this dog. And you saw a little bit of sort of laryngeal contraction, a little bit of movement, but it's hard to tell whether that was just a cough or sort of a expiratory cough reflex than true normal abduction. But then this video on the right is the same dog with 1/2 mg per kg.
No.
Yeah.
Done.
Oh, now it's just open forever. Okay, well, Yeah, okay. Now it's just forever. Then.
Really working, guys. Yeah, 109. Oh, gosh, 145 mark 8.
I'll just laugh about it. What's that? I just laughed. The kind of his wisdom. Oh.
Really? That's not one.
And.
Coming back down again.
Is it up top?
Yeah.
Oh, yeah. Hello.
Wearing off, you know, I think.
Oh. Side.
Well, that was fun.
Not the dog. I'm gonna have to go to the west side. Second, 78. I don't think it was ever.
Great.
The west side.
There's a good one.
Yes, I'm gonna call it.
West side.
The one west side, that is. I think it's stuck up. I'm pretty positive.
So a few more normal breaths there.
91.
Okay. That was exciting.
That was.
It was like a roller coaster.
All right, yeah. So just an example, I left the video or the audio on just for some of that banter that goes on as we're doing these exams and kind of get a sense of the different people looking at the ECG and the heart rate, respiratory rate. We're looking at the larynx. But yeah, a dramatic difference of the quarter versus half mg per kg. And this was a dog that had older large breed dog that had some unusual respiratory signs according to the owner, and we were looking at it actually for our internal medicine service to rule in or rule out laryngeal paralysis. His signs seemed more nasal based on their assessment, but still wanted to rule out the status of the larynx. And so for me, a good example of how you don't want to give this dog a false diagnosis of laryngeal paralysis when it doesn't indeed have it. And so the example of using Doxapram to override the depressant effects of the induction agent so that we make the accurate diagnosis, I think was important. And then further highlight sort of the difference between a quarter and a half mg per kg. And so I'll use either one, but I've sort of gravitated toward using, because of this, gravitated to using a half mg per kg in most cases, unless there's any other sort of concerns or risks. But hopefully that's a good example for everyone of the impact of Doxapram. And I've got a couple others here. This is another dog. This is an older Labrador Retriever that was given ACE and butorphanol and propofol sort of as we talked about earlier for it as its combination. And just take you through it here.
I think he looks apneic up here. Well, that's great. Old Labrador. So my parents are Labrador.
So he's breathing pretty good. We can't see his chest excursions, but he's breathing pretty good, but not much happening. A little bit of flutter.
Yeah. Yeah.
You can see the saliva kind of flowing, the vocal cords kind of fluttering.
Great.
But nothing really happening. But at the same time, not convinced because his respirations are not particularly deep.
Yep.
So
I think he looks apneic up here.
yeah, so just not confident enough to call it yet with that protocol or with that assessment. So then this video clip is of the same dog with ACE, butorphanol, propofol, so same combination plus Doxapram. So again, you'll see the impact of that or the value of that. This is about a 90-second clip. So just the Doxapram going in. And then sort of same laryngeal view. So you can see his rate got a little stronger, a little faster.
Yeah, it's only, yeah.
You can sort of see him. Just more forceful. So that's the Doxapram kicking in there. But just no motion, which, we gave this dog bilateral laryngeal paralysis based on this assessment. Good deep breaths, Doxapram, stimulated deep respirations, strong respirations, but no motion of his arytenoids. You could see the saliva kind of flutter. You could see the vocal cords flutter, actually slightly paradoxical, but no enlargement of his rima glottis. So this dog, we were confident in our diagnosis based on the laryngeal examination and the lack of motion even after Doxapram or Doxapram administration. And just another example here. I saw this dog just a couple weeks ago. Older golden retriever, had a little nodule on his larynx on the just above the vocal cord right here. And this dog had laryngeal paralysis. We gave it that diagnosis, I'll tell you that. But then, but he wasn't that badly affected, and so the owners were reluctant to consider surgery because he was doing relatively clinically well, despite the stridor, despite some coughing episodes. He was still fairly active, and part of the reason for the exam was just to assess his rima glottis, and at rest he had a pretty good opening. I think just his normal conformation allowed him to have caused him to have a pretty good opening. So he wasn't that affected, with normal activity, even though he was paralyzed. So he happened to have a pretty good opening, a pretty good rima glottis, and that I think allowed him to cope and do better, say, than a lot of other dogs. But just to be sure, this is that same dog after Doxapram. So his larynx is moving a lot. It's a little better. There you go. So he's moving a lot, but it's all paradoxical. So he's sucking in on inspiration and he's blowing it out on expiration. So that's inspiration, that's expiration, inspiration, expiration. So if you just look over someone's shoulder real quick, you'd think, well, that's moving, he's good, but it's actually all paradoxical. And that's the Doxapram. It's stimulated his respiration so much that he's breathing so deep and he's creating so much negative pressure through his airway that he's sucking everything in. So, and I imagine this does happen at activity or when he is active, but I think he's coping with it enough. So we ended up not pursuing anything surgical at the moment, but just an example of paradoxical motion when you stimulate their breathing enough, and just a good example of proving that he's paralyzed and then just observing the paradoxical motion. And this is the situation where some people run into where they have to intubate, or they can get into a little bit of trouble if they're breathing so heavily that they obstruct due to the paradoxical movement or collapse of the larynx. So be cautious, be prepared to intubate if you have to, but he was fine, and this wore off in about 15 seconds. But again, just a good illustration of paradoxical motion. And some other just quick clips of what that looks like. This dog on the left has just got a little bit of vocal fold movement. So it looks like he's moving, but if you notice, everything is moving inward. At no point does he actually enlarge his remiglottis. It always just gets smaller. And the corniculates and the cuneiforms, they don't ever lateralize or get any wider. So, and this one on the right, sort of similar thing happening. It's fluttering. And on inspiration, he kind of sucks it in. On expiration, he kind of pushes it out. But there's never any sort of intentional or legitimate or solid lateralization of that or of those arytenoids. So just another example of paradoxical where it looks like it's moving and you could make the wrong diagnosis if you're not careful. So I see a couple questions. Is something we want to jump into now, Quincy, or do you think we got a couple cases, just a couple quick cases just to highlight some interesting findings on a couple of dogs. But
Sure, yeah, we had a couple come in. I don't know can you see them?
I just see the Q&A. I don't see the actual question itself.
Okay, so one person was asking if you'll be talking about unilateral paralysis and which one is more common.
Oh yeah, good question. Yeah, in dogs, it would be it's not hard to make the diagnosis per se, but a dog with unilateral paralysis, if it was iatrogenic or experimental or whatever, they can usually do clinically pretty well. In other words, most dogs with unilateral paralysis, for whatever reason, would probably cope and probably would not need surgery and probably wouldn't need any other sort of medical or conservative management I'd say in most cases, if they had a normal larynx and they weren't suffering from collapse or any other, comorbidity. So I'm not sure if you have a specific example, but I can think of, say you did thyroid surgery or removed a thyroid tumor and the recurrent laryngeal nerve got damaged, or it was a traumatic injury or something like that. It wouldn't be, it wouldn't be great, but you wouldn't worry about it, I think, from a clinical perspective, the same way you would if it was bilateral. So most dogs can get away with unilateral paralysis and still be fairly normal in terms of their activity, exercise tolerance, and so forth. I think it's different for cats, but for dogs, most unilateral cases can be okay. I don't know if there's any more specific details that I can answer. But they might sound a little funny. That paralyzed side might flutter, might cause some stertorous breathing, but they can usually cope.
Okay. And then the next one was, thanks for the presentation. The videos are particularly helpful and also a reminder to have patience and take time in the examination, no rushing. So just enjoying your presentation so far.
Oh, good, thanks. Yeah, so not too much more. I just wanted to take those just in case they were related to the last last couple of videos. But then, just a couple of quick cases I just wanted to present that highlight some maybe a bit unusual or a little bit sort of cautionary tales, and why I guess pays to be thorough, or why you don't want to assume too much in terms of your presumptive diagnosis when you see an older large breed dog come in that's got a history of stridor and voice change or whatever. And this dog exemplifies that. This is I'll get rid of that. Yep. A 9-year-old mixed breed dog that had a 1-month history of voice change, had some stridor, and had some moderate episodes of respiratory distress according to the owner. And here's his, I'll turn the volume up as much as I can. Hopefully you can hear him.
We can hear a bit, but you might want to turn it up just a little bit more if you can.
That's as loud as it goes. So yeah, so I'd mimic it if I could, but he sounds a little bit hoarse. He's trying to bark and it's kind of coming out muted. And that's been going on for a month or over a month. And that coupled with his stridor and coupled with a couple of episodes of respiratory distress when he got excited, the owner brought him to us. And so he kind of sounded like a LARPAR dog to us. You know, he's an older, not a large breed, but kind of medium to large breed dog, older. He's in the age frame for dogs with laryngeal paralysis, idiopathic or acquired laryngeal paralysis. He had the stridor, he had the distress episode, so he's kind of fit in the picture. And then as I always do, I radiographed his chest and his neck area. So I do a lateral cervical view, and this is the view or the image we got of his larynx. And I wonder what you guys think, but it's not a place we look at all the time, but you can see his hyoid here. You can see this would be his epiglottis right here. You can see the cuneiform process here, and the corniculates are right here. And this is the vocal, or the vocal recess, or oftentimes they'll get a little air in that area between the vocal cord and the rytenoid cartilage. So you're kind of looking at the side of the larynx. Hopefully my cursor is showing up. And then here's the thyroid cartilage, and then the cricoid cartilage, sort of as they overlap each other. But if you look close, it just looks a little fuzzy. Looks a little hazy, a little fuzzy, not real crisp. Say compared to you can see the tracheal rings, more caudally. You can see the epiglottis, you can see the hyoid. So in contrast, it looks a little fishy. So we did our laryngeal exam, and this is what we saw on that. So you can see he's breathing kind of based on you can see the saliva kind of moving back and forth. So you can tell he's breathing. You can see the vocal folds flutter a little bit, but no motion. And he was fixed. And this kind of goes back to what I was talking about earlier, when you try to maneuver or manipulate the rytenoid cartilages to make sure you don't have any sort of fibrosis or ankylosis or invasion by a tumor. And so when we tried to lateralize those, or take the laryngoscope or the tongue depressor and push them, we weren't able to get any kind of motion laterally with either a rytenoid cartilage. And so it looked like just had a fixed, invaded larynx. And so his chest radiographs, we had done those at the same time as the cervical films. But you can see this dog ended up having squamous cell carcinoma of the larynx. And then here you can see the pulmonary metastasis. But just an interesting case, because in the first maybe 30 minutes, we were all kind of walking around wondering if this dog had laryngeal paralysis of the typical type, which was, would be acquired or secondary to that degenerative axonopathy. And he would just kind of fall in line with the rest of them. But he was a little different. He was a different breed than most. He wasn't as big as most. He was a little younger than most. There's a few other things about his history and his signalment and his clinical signs that didn't quite fit. But just going back to his x-ray, you couldn't feel this at all. This all felt completely normal. So physical exam, sort of palpation of his cervical area was normal. But on radiographs, it did look suspicious. Laryngeal exam, he's definitely fixed. And then obviously with the thoracic radiographs showing pulmonary metastasis, we eventually made the diagnosis of squamous cell carcinoma that was just wrapping around or involving the laryngeal cartilages to an extent that his larynx became fixed. And essentially at that point, he did have a form of laryngeal paralysis. It was just put for a different reason. So interesting case for me there. And this guy here, 11-year-old female Labrador Retriever, really the poster child for acquired laryngeal paralysis. And his history, or her history, was a progressive respiratory stridor over 6 months, progressed to exercise intolerance, and then she also had a couple of collapsing episodes. So in many ways, just based on the history, she was a surgical candidate. You know, her degree of exercise intolerance and the collapsing episodes had everybody worried. So just from that, we were like, well, this is probably a surgical case. But let's, finish the diagnosis, rule everything else out, and then, talk through the pros and cons, the risks and benefits, which I realize I haven't gone into anything about the surgery and all of that, but that was our thinking. And then here is that typical cervical radiograph that I talked about that I always do. And have a close look and see if you guys see anything. So we took it, the chest was clear, no evidence of aspiration pneumonia, no evidence of megaesophagus. So from that perspective, we were happy to move forward. On our original pass, we didn't see much to worry about on these cervical films. So we did our laryngeal exam, and that was paralyzed. And this is what we found in surgery. So we're doing a left lateral approach to the larynx. So the typical sort of lateral approach to the larynx, and you can see the wing of the thyroid cartilage is right here. So there's a stay suture just at the bottom of the surgical field, a stay suture on the wing of the thyroid cartilage, lateralizing that. And this is what we found sitting on top of the cricoid cartilage. So a little surprise here. And then turned out to be a chondrosarcoma. And so it's about the size of a grape, or it's about 1.5 to about 2 centimeters long. And this is where it was sitting. And if you go back to this X-ray, I think if you look closely, and there are some skin folds overlying, so it's a little tricky to see, but in hindsight, we missed this lesion right here, sitting on the wing of or underneath the thyroid, on the wing of the thyroid and on top of the cricoid cartilage. And you can see the back side of the cricoid cartilage right here. This is the cricoid, it's kind of triangular shape, and the thyroid is overlying all of that. So, we did a left lateral approach, and then this was in the way. We were able to peel it off, and it came off fairly discreetly. And it was sitting right over the muscular process where you would normally place your sutures for a tieback, but we were able to get the tieback sutures in pretty normally, actually. So this thing kind of peeled right out of there, luckily. And then placed our sutures, and then tied the dog back as we normally would, and got pretty much the same type of lateralization, even though we were kind of working around a previous tumor site. But again, just another sort of cautionary tale or case to cause you to really, really look close at your radiographs and not just assume, that every 11-year-old black lab has got the same thing. And indeed, I do think this dog probably had degenerative neuropathy due to being an older Labrador, and the dog also did have some hind limb signs. So I think it had all of the usual things for a typical LARPAR dog, but also happened to have a chondrosarcoma sitting on their cricoid cartilage. And this is her post-op. So sounding a little harsh, a little hoarse, but recovered well. And she recovered well and then went on to be fine in the short to intermediate term.